In this disease, students, there will be some problem in gaseous exchange. Either oxygen is not properly coming into your body or carbon dioxide is not going out from your body. This phenomena is called as respiratory failure. Let us see what is respiratory failure. Respiratory failure is characterized by either low PaO2, that is PaO2 less than 60 mmHg. This phenomena is called as hypoxemia, or high PaCO2, that is PaCO2 more than 45 mmHg. This phenomena is called as hypercapnia. Either oxygen is less in your body or carbon dioxide is more. This phenomena is called as respiratory failure. Let us see the types of respiratory failure. We have 4 types. Type 1, it is hypoxemic. It is hypoxemic respiratory failure. Type 2, it is hypercapnic. It is hypercapnic respiratory failure. It is a hypercapnic respiratory failure. These two are very common in clinical practice. I will explain with help of a table in the next slide. Less common types that we see are type 3 respiratory failure. This is a perioperative respiratory failure. This is a perioperative respiratory failure due to lung atelectasis, associated with general anesthesia, due to lung atelectasis associated with general anesthesia. Whereas type 4, this is due to hypoperfusion. This is due to hypoperfusion of respiratory muscles, as in shock. Hypoperfusion of respiratory muscles as in shock. Now let us see type 3 respiratory failure. Whenever I give general anesthesia to a patient and perform surgery, what exactly we are doing? We are completely knocking down the patient. After the surgery is over also, the effects of general anesthesia on your respiratory muscles can persist for few days. That's why once the patient is regaining consciousness after a major surgery, I ask him to do some deep breathing exercises. So why is it so? If we do his deep breathing exercises, still your lungs have not completely recovered from general anesthesia. By doing deep breathing exercise, there will be facilitation of alveolar expansion and proper gaseous exchange. Now if the patient is not doing breathing exercises properly, lung will not expand, alveoli will not expand, resulting in lung atelectasis. Whenever there is lung atelectasis, there will be no proper gaseous exchange, that will result in respiratory failure. This respiratory failure in operation theatre setting, general anesthesia associated, it is called as type 3 respiratory failure. Next, coming to type 4. Even my respiratory muscles need some blood supply for function. Now in shock, ultimately the blood reaching the respiratory muscles will decrease. Now because your respiratory muscles also require some blood supply to function, there is no proper blood supply, your respiratory muscles will stop functioning, there will be no proper gaseous exchange. So this respiratory failure in setting of shock is called as type 4. In setting of general anesthesia operation theatre, it is called type 3. But in routine clinical practice, commonly we see will be type 1 and type 2 respiratory failure. Let us learn this type 1 and type 2 respiratory failure with help of a table, students. So this is the important table which will describe the type 1 and type 2 respiratory failure. Before going into the type 1 and type 2 respiratory failure, let us see what is normally happening. Normally, my alveoli will have oxygen called as P capital A O2. This will be about 100 mm Hg. Ultimately, oxygen will reach my blood vessel. This is P small a O2. That is 90 mm Hg. So this is about 90 mm Hg. Always between alveoli and artery there is a oxygen gradient difference, P capital A minus small a O2. Alveolar oxygen minus arterial oxygen. It will be about 10 mm Hg. This is called as alveolar arterial gradient. Alveolar arterial gradient. This is alveolar arterial gradient. See, the range is usually 5 to 15 mm Hg. The reference value we take it as 10 mm Hg. This is something normally happening. Let us see what happens in type 1 respiratory failure. Again, let this be the alveoli, let this be the blood vessel. Now in type 1 respiratory failure, the problem is any defect that results in decreased transfer of oxygen, and most importantly there will be a diffusion defect. There will be a diffusion defect. What happens here is oxygen will reach the alveoli. Oxygen is reaching the alveoli. There will be some problem within the alveoli. Alveoli might be filled with secretions, or around the alveoli there can be deposition of fibrous tissue. Because of this, this oxygen cannot go completely into the blood vessel. So either secretions within the alveoli, or around the alveoli deposition of fibrous tissue, or some issue in the pulmonary circulation. Ultimately, the amount of oxygen reaching the circulation will be less. In this condition, P capital A O2 is normal, whereas P small a O2 is significantly reduced. Now if you see the gradient, P capital A minus small a O2, if you calculate the gradient, 100 minus 50, it will be about 50. So the gradient is significantly elevated. Then what happens to PaCO2? PaCO2 will be normal or only slightly decreased. Now you should get a valid doubt, students. It is the same membrane. It is the same membrane where oxygen is finding its way difficult into the body. How come CO2 is going out easily? There are two reasons behind this. When compared to oxygen, solubility of CO2 in your body is higher. Solubility of CO2 higher. So this is the first reason. And second reason, whenever there is less oxygen, there will be hypoxemia mediated hyperventilation. So whenever there is less oxygen, there can be hypoxemia mediated hyperventilation. Because of these two reasons, CO2 can still easily go out. Very, very important. When compared to oxygen, the solubility of CO2 is 20 times more higher. Solubility and diffusibility. It might be difficult for oxygen to come in, but still CO2 can go out easily. And moreover, whenever there is a hypoxemia, the hypoxemia will cause hyperventilation. As long as patient's respiratory drive is there, it will be driving out CO2 out. Because of that, either CO2 can be normal or decreased. It will not be elevated. Now what can be the causes of type 1 respiratory failure? First group, it can be alveoli filled with secretions, alveolar flooding, alveoli flooded with secretions. This can be seen in severe pneumonia. And next condition is ARDS, acute respiratory distress syndrome. Second thing, around the alveoli, deposition of fibrous tissue, fibrosis, interstitial lung disease. Some issue in pulmonary circulation, that is pulmonary embolism. These are the important causes. These are the important causes of type 1 respiratory failure. Now let us see type 2 respiratory failure. Here the problem is either hypoventilation or any defect that is responsible for decreased respiratory effort. Hypoventilation or any defect that is responsible for decreased respiratory effort. So what is happening here? Again, let this be the alveoli, let this be the circulation. So whenever I say hypoventilation, decreased respiratory effort, what is happening? When my respiratory effort is normal, during inspiration I take good amount of oxygen, reflexly during expiration good amount of carbon dioxide is going out. When my respiratory effort is not proper, insufficient inspiration, so the amount of oxygen coming into my body will be less. Insufficient expiration, CO2 exit will also not happen properly, because CO2 is not going out from my body, CO2 will start retaining in my body. So here what happens is the amount of oxygen coming into the body itself is less. The amount of oxygen coming into the body itself will be less. So instead of 100, only 60 will come into the body. So P capital A O2 will be reduced. P capital A O2 will be reduced. When the membrane is healthy, a constant fraction can go into the circulation. P small a02 will also be reduced. Then what happens to the gradient? P capital A minus small a02. So here gradient 60 minus 50, it will be 10. So the gradient can be normal. The gradient can be normal. Then what happens to PaCO2? Because expiration is not properly happening, PaCO2 will be elevated. PaCO2 will be elevated. So PaCO2 will be elevated, students. Now whenever CO2 increases, automatically there will be decrease in pH. Because there is decrease in pH, this is called as acidosis, and this is due to CO2, it is called as respiratory acidosis. In your body, acid is CO2, base is bicarbonate. Why it is so? We will discuss in acid base balance. Because acid called as CO2 has increased. Any increase in acid will decrease pH. Decrease in pH is acidosis. This is due to CO2. It is called as respiratory acidosis. Coming to causes. What are the causes of type 2 respiratory failure? The first group, it can be a central cause. Things happening at the level of brain. We have brain stem injury. It can be due to a brain stem injury. It can be due to narcotic use. Now how come brain stem injury will be responsible for type 2 respiratory failure? What is the reason behind that? See, within the brain stem there is your respiratory center. When it is damaged, your respiratory center will not function. Decreased respiration, that will result in CO2 retention. Narcotics, they themselves can cause respiratory depression. Second cause, obstructive causes, obstruction within the airways, such as a large foreign body within the trachea, a large foreign body within the trachea, severe COPD, large foreign body, severe COPD. Now whenever there is a large foreign body, especially in the trachea, during inspiration, the amount of oxygen going into your body will decrease. During expiration, CO2 will not come out. In severe COPD, there will be extreme narrowing of airways. Whenever airways are extremely narrowed, during inspiration, oxygen cannot go inside. During expiration, carbon dioxide will not come outside. Because CO2 is not coming out, it will increase in the body, resulting in carbon dioxide retention. Third cause, peripheral causes. Central means something happening at the level of brain. Peripheral means something happening on the chest wall. Over the chest wall, your respiratory muscles have become weak. We have neuromuscular disorders. Already I have discussed the neuromuscular disorders association with respiratory muscle weakness. Polio, myasthenia gravis, Guillain-Barré syndrome, amyotrophic lateral sclerosis. In all these, respiratory muscles become weak, there will be decreased respiratory effort. Finally, what is the strongest respiratory muscle? Diaphragm. Whenever there is a diaphragmatic injury. The causes of type 2 respiratory failure you can easily remember with a simple mnemonic called as COPD. Central cause, obstructive cause, peripheral cause, diaphragmatic cause. And moreover, most common lung disease responsible for type 2 respiratory failure. Your answer is COPD. Most common lung disease responsible for type 2 respiratory failure. Most common lung disease responsible for type 2 respiratory failure. Again, your answer should be severe COPD. So in this table, students, we have understood the differences between type 1 respiratory failure, type 2 respiratory failure, the causes, the pathophysiology. And most common lung disease responsible for type 2 respiratory failure is generally severe COPD. So whenever, let it be any type, type 1 or type 2, if there is a respiratory failure, it is an emergency, patient will be in emergency department or ICU. So what will be the initial treatment? Initial treatment will be giving him some oxygen and trying to treat the underlying disease. Now the underlying disease, if it is due to some pneumonia, I give him antibiotic. If it is due to some bronchospasm, I give him nebulized bronchodilators. If it is due to some foreign body, I will try to retrieve the foreign body. So write down treatment. Treatment for respiratory failure. So initial will be oxygen, and I treat underlying cause. I start to treat underlying cause. If not improving, if patient not improving, this patient requires assisted ventilation called as mechanical ventilation. He requires mechanical ventilation. Now what is this mechanical ventilation? It is a positive pressure ventilation. We are going to give oxygen with positive pressure ventilation, written as PPV. Based on the method of delivery, mechanical ventilation can be classified into two types. We have invasive mechanical ventilation, written as IMV. Then there is non-invasive ventilation called as NIV. We have IMV, NIV. What is IMV? This is positive pressure ventilation delivered through endotracheal tube. You are putting a tube in the trachea and you are giving positive pressure ventilation. That is called as invasive mechanical ventilation. Non-invasive, the positive pressure ventilation delivered through a tight fitting face mask. In simple words, if you give positive pressure ventilation through a tube placed in the trachea, it is called as invasive mechanical ventilation. Positive pressure ventilation through a tight fitting face mask, it is called as non-invasive ventilation. It is called as non-invasive mechanical ventilation. Now I'll show you some images. By seeing those images, you should tell me what is invasive mechanical ventilation and what is non-invasive mechanical ventilation. So these are the images, students. Now image 1. What do you see in image 1? This is a ventilator. And it is going to give positive pressure ventilation. Now how it is being delivered? With a endotracheal tube, ET tube. What is this called as? This is called as invasive mechanical ventilation. Now image 2. This is a ventilator. This will also deliver positive pressure. How is it being delivered? Through a face mask. So what is this called as? Non-invasive ventilation. Let us see the important advantages of invasive mechanical ventilation. What is the biggest advantage of this endotracheal tube, especially in unconscious patients? So whenever a patient is unconscious, his cough reflex will be completely lost. So there will be lot of secretions getting pulled up in his oral cavity, and that can easily aspirate into his lung. So whenever I put a tube within the trachea, it is going to prevent large volume aspirations. Endotracheal tube means your airway is secured. It is protected from large volume aspirations. The biggest advantage of IMV is airway secured. And this is considered as preferred method. Of ventilation in type 1 respiratory failure. Now what is the reason behind this? What exactly is the problem in type 1 respiratory failure? Oxygen is coming into the alveoli. It is not going into the blood circulation. Now tell me, students, pressure at what level is important? So is it pressure at the nose or giving pressure directly into the lung? If you give pressure directly into the lung, that pressure can push the oxygen into the circulation. So for better transfer of gases, you need to give invasive mechanical ventilation. If you give pressure directly into the lung, that pressure can push the gases into the circulation. The reason is IMV will cause better transfer of gases. Coming to NIV. The first prerequisite for giving NIV is very, very important. Patient should be conscious and coherent. You cannot give this in unconscious patients. What is the reason behind this? I told you, whenever a patient is unconscious, his cough reflex will be completely lost. So if you seal his face with a mask and if you push air with positive pressure, all those secretions from his mouth will definitely go into lung and patient will die of asphyxiation. That's why there are some contraindications to NIV. So write down NIV contraindications. NIV contraindications. Never give it in unconscious patient. Unconscious patient. Risk of aspiration. Altered sensorium. A patient in altered sensorium will have altered cough reflex, students. Uncooperative patient. If the patient is uncooperative, he can easily pull out the mask. Now my question is, can you give IMV in uncooperative patient? Whenever you are giving IMV, you are completely sedating the patient. You are knocking the patient down. So there is no point of cooperation or non-cooperation. He has to bear with it. Whereas in NIV you cannot give sedation. If you give sedation, there can be respiratory depression, CNS depression, unconsciousness, and there can be increased risk of aspiration. Don't give NIV in cardiac arrest. Cardiac arrest itself means patient is unconscious, unresponsive. Patient is unconscious, unresponsive, cardiac arrest. Hemodynamically unstable patient. Hemodynamically unstable patient. I don't know when this patient is going into cardiac arrest. So there is no point in giving NIV. Then patient with recent nasal surgery. Patients with recent nasal surgery. And also active GI bleed. Now why I should avoid in patients with recent nasal surgery? Because here you are not only giving positive pressure through the mouth, you are giving it through the nose. Whenever there is a recent nasal surgery, that positive pressure can damage the surgical wound. Whenever surgical wound is damaged, blood can leak. So blood from the nose can go backward into the trachea, resulting in asphyxiation with blood clot. Coming to active GI bleed. Already patient is having hematemesis. So if you seal his face with a face mask, if at all patient develops blood vomiting, it will not go out. It can go backward into the lung. Again patient will develop asphyxiation with blood clot. These are the conditions where NIV is strictly contraindicated. With respect to respiratory failure, this NIV is a preferred method. It is preferred method, especially in type 2 respiratory failure. By the time a patient with type 2 respiratory failure reaches me, he will be generally having severe COPD, chronic obstructive pulmonary disease. Now tell me students, why in severe COPD we don't consider IMV as first line of mechanical ventilation? In COPD emphysema, there are hyperinflated areas called as bullas. Already a balloon is stretched to its maximum capacity. Now if you pump more air into that area, that balloon can rupture, bullas can rupture, resulting in air escaping into pleural space, causing a dangerous complication called as pneumothorax. Moreover, in NIV you are not putting any tube. In IMV you are putting a tube. So when there is a tube and it is connected to a ventilator, that ventilator itself is a huge source of microorganisms. From the ventilator, the organisms can go into the tube. From the tube, it can go into the patient's lungs and cause ventilator associated pneumonia. Already a patient with severe COPD, his lung condition is bad. If at all a new infection develops, it becomes worse and it can result in mortality. If you do invasive mechanical ventilation, high chances of pneumothorax and ventilator associated pneumonia. That's why you try to avoid invasive mechanical ventilation. You try to maintain with NIV. The biggest advantage of NIV is decreased risk of pneumothorax and ventilator associated pneumonia. Decreased risk of pneumothorax and ventilator associated ventilator associated pneumonia, VAP, also written as VAP. Now if not improving with NIV, only as a last resort IMV done. Remember, if not improving with NIV, only as a last resort IMV is done. Now I'll give you some clinical scenarios. Tell me what to do next. There is a patient with COPD. He is having type 2 respiratory failure. He is unconscious. What will be the preferred method of ventilation? See, COPD, type 2 respiratory failure. You might be attracted towards NIV, but the point here is patient is unconscious. In unconscious patients, you cannot give NIV. So here answer will be IMV, invasive mechanical ventilation. Another question, COPD, type 2 respiratory failure, patient is conscious oriented. Here what should be the preferred choice? It is NIV. So students, there are no hard and fast rules that this patient should be only kept on NIV or IMV. Depending upon the patient's current situation, you should assess and decide what is best for the patient. So this is regarding respiratory failure, the management part, the differences between IMV, NIV, the indications and few contraindications. Let us try to solve a question. Case number 8. There was a 25-year-old male patient like this. He was brought to the emergency department, found unresponsive at home. He is having IV drug abuse, HIV, medical non-compliance, CD4 count was low. On initial evaluation, his vitals and ABG parameters are given. They are asking you which of the following respiratory failure is predominantly seen. Now if you notice here, his pH 7.16, his PaCO2 70, his PaO2 55. There is both hypoxemia and hypercapnia. Remember this students, hypercapnia is the deciding factor. Whenever there is hypercapnia, you should call it as type 2 respiratory failure. The answer is type 2 respiratory failure. The answer is type 2 respiratory failure. Now they can extend the question like this. What is the cause of type 2 respiratory failure in this patient? Now is it HIV related any pneumonia or is it something else? This patient is having IV drug abuse. It can cause CNS depression. That might be the reason for his unresponsiveness. It can cause respiratory depression. That might be the reason for his decreased respiratory effort. Both put together can cause CO2 retention. So the cause here for type 2 respiratory failure will be narcotics. This is how you should approach to respiratory